Welcome to The Explainer. Today, we're jumping straight into the ER for a high-yield, rapid-fire look at one of the most common and, honestly, most frequently mismanaged clinical scenarios you'll face on shift. We're going to break down the critical difference between a scary number on a monitor and a true life-threatening crisis.
Picture this. It's 2 a.m. You're mid-shift in the ER. The monitor alarm starts blaring for your next patient, and you look up to see a jarring blood pressure of 230/130. A nurse turns to you and urgently asks, "Doc, should we bring this pressure down immediately?"
You pause, because before you touch a single antihypertensive medication, before you even think about reaching for a prescription pad, there is literally only one clinical question that truly matters. You have to ask yourself, is there acute target organ damage? Section 1. First decision. Are we dealing with an emergency or just a very high BP?
Look, an isolated high number alone does not mandate a frantic medical reaction. You can easily have a patient sitting comfortably in front of you with severe asymptomatic hypertension, say 180/120 or higher, and absolutely zero organ injury. That is not an emergency. A true hypertensive emergency is defined strictly as a severe blood pressure elevation combined with acute, ongoing target organ damage. We're dropping outdated terms like malignant hypertension here. It is all about that acute injury.
And here's a critical caveat to keep in your back pocket. There's no absolute threshold number to memorize. Why? Because patients with previously normal baseline pressures can suffer massive emergency organ damage at much lower readings. Think about a pregnant patient developing eclampsia or a young adult with acute glomerulonephritis. A rapid rise from their normal baseline can cause severe injury long before they ever hit 180/120.
Section 2. Don't stare at the number, find the organ.
You have to stop staring at the monitor and shift your focus entirely to the patient. In those first few minutes, initiate a rapid head-to-toe ER scan and ask which organ is being injured right now. Let's fire through the clinical clues. Brain. Are they confused, agitated, having seizures or focal deficits? Eyes. Do you see flame hemorrhages or papilledema? Heart and lungs. Is there chest pain or pulmonary edema? Aorta. What about sudden, tearing back pain? Check those kidneys for acute injury. And absolutely always ask about pregnancy or recent use of hyperadrenergic drugs like cocaine or amphetamines.
Once you suspect a specific organ, your diagnostic tests have to be directly guided by that suspicion. This isn't just some blind, one-size-fits-all checklist. Suspect cardiac ischemia? You get an ECG and biomarkers. Heart failure? Grab a chest x-ray. Checking the kidneys, urinalysis, and serum creatinine. If you suspect neurologic injury or an aortic dissection, you are heading straight to a CT or MRI. The damaged organ completely dictates your workup.
All right, Section 3, the most important treatment rule.
A lot of junior clinicians have this dangerous knee-jerk reaction when they see a massive reading. They immediately want to drop it to normal. But that instinct is flawed, and it all comes down to autoregulation. Vascular beds habituate to sustained severe hypertension, basically resetting their baseline to require higher pressure just to push blood through. If you drop the pressure too rapidly, you critically reduce perfusion to the brain, heart, and kidneys. That causes disastrous ischemic injury. Lower is definitely not always better.
So how do we actually do this safely? Well, for most hypertensive emergencies, the general consensus is to carefully drop the mean arterial pressure by about 10 to 20% in the first hour. Then, over the next 23 hours, you gradually reduce it by another 5 to 15%.
In practical numbers, that typically means aiming for a target of less than 180/120 during that first hour. Over the next 23 hours, you're slowly bringing it down to less than 160/110. Let me be crystal clear on this. You are explicitly forbidden from immediately normalizing their blood pressure.
This entire overarching philosophy comes down to one simple, memorable phrase. Treating a hypertensive emergency requires a controlled descent, not a crash landing. Just keep that metaphor in your head every single time you adjust an IV drip.
Section 4. 3 life-saving exceptions. Because it's medicine, there are always exceptions to the rule, right? We're going to open 3 clinical ER doors to show you the major landmines where that slow and steady, controlled descent golden rule absolutely does not apply. We're talking acute ischemic stroke, acute aortic dissection, and spontaneous intracerebral hemorrhage. Depending on the door, your targets are radically different.
Let's drill down into acute aortic dissection. For this one, throw the slow and steady rule completely out the window. Here, you need to rapidly crash the systolic pressure down to 100 to 120 millimeters of mercury within 20 minutes
to reduce shearing forces on the aorta. Crucially, and I cannot stress this enough, you must give an IV beta blocker like esmolol first to reduce the heart rate before you ever touch a vasodilator.
Next exception, acute ischemic stroke. In this scenario, we actually use permissive hypertension. You generally do not lower the blood pressure at all unless it hits 185/110 in patients who are candidates for reperfusion therapy, or a massive 220/120 for non-candidates. The brain desperately needs that pressure to perfuse the ischemic penumbra.
And the third exception is spontaneous intracerebral hemorrhage. This one's a bit of a conundrum for us. We know that rapidly reducing the systolic pressure with agents like IV labetalol or nicardipine appears to be totally safe. However, the data showing that this rapid reduction actually provides long-term clinical benefits, well, that remains frustratingly controversial and unproven.
Beyond those three massive exceptions, here are a few highly specific drug rules you just have to memorize. In acute heart failure with pulmonary edema, avoid beta blockers. Use loop diuretics and titratable vasodilators instead. For cocaine-induced sympathetic overdrive, never use unopposed beta blockers. Reach for phentylamine. And for severe preeclampsia in pregnancy, hydralazine or labetalol are going to be your go-to agents.
Okay, final section. Section 5, Crucial Post-Acute Care.
So you've survived the first 24 hours. You've successfully navigated the acute crisis window with IV drips in the ICU. Now your clinical focus must radically shift from immediate rescue to stabilization. First step, safely transition the patient off the IV drips and onto oral medications. Second, you really have to evaluate them for secondary causes of hypertension, because those are highly prevalent in patients who suffer these types of emergencies.
And third, and this is perhaps the absolute most important aspect of their entire post-acute care, you must secure high-quality outpatient follow-up. Why? Because a lack of outpatient follow-up basically guarantees that this patient is going to bounce right back into your ER with another devastating crisis.
Which leaves us with one final thought to close out this explainer. You now know exactly how to save their brain, heart, and kidneys in the middle of the night. But as they transition out of your care, ask yourself, how will you ensure your patient doesn't bounce right back to your ED? Mastering the acute emergency is only half the battle. Setting them up for long-term success is what truly saves lives.